So we're going to start now the session. Thank you very much. So maybe we can close the doors on the back, just make sure that we don't have a lot of background noise. So my name is Jaime Ponce. I'm a bariatric surgeon in Chattanooga, Tennessee, United States. I'm president of the North America chapter from IFSO. So I'm excited to be here. The main moderator of this session is not available. He couldn't come to the meeting, but we're going to run a good meeting. This is a good topic. It's actually a good topic on situations in which you are going to face it in many instances. And so metabolic and bariatric surgery in functional indications, joints, and hernias. That's a very nice title. So I'm going to start, and my co-moderator is Nasser Sakram. He's going to be hopefully here with us soon. I'm going to start with Ahmed Ali. He's going to talk to us about metabolic surgery in patients with large ventral hernias. And so that's going to be an exciting topic. Thank you.
All right, thanks, Jaime. Good afternoon, everyone. Thanks for joining us in this session. Again, welcome to Melbourne on behalf of everyone of the organising committee. I think all of us have had a background in general surgery and perhaps now specialised in bariatric surgery. We've all come across hernias and perhaps deal with it every day in our practice. These are my disclosures. There's really not too much there. Ventral hernias are important. They're actually more significant than perhaps we give them attribution. They do have a significant impact on quality of life. That's been demonstrated in many quality of life studies. They cause chronic pain, physical impairment, as well as just the psychological impact and the potential cosmetic association of it. And the other thing is that treatment does improve these parameters. So treatment is associated with improvement in quality of life. It does reduce pain and overall patients, even when they suffer a recurrence, tend to maintain a better quality of life having had the hernia addressed. But in our particular circumstance where we deal with patients living with obesity and we have hernias, then we get faced with some really challenging types of situations, or the general surgeon perhaps doesn't operate in the bariatric world, is presented with these patients, and of course their response is, well, this is very difficult. I think we need to lose weight. And it really does depend on your perspective. So if you're the hernia surgeon, you look at this situation, you say, this is technically difficult, it's not safe to do. If I do it, the results are poor, recurrence is going to be high. So I'm sorry, I really can't help right now, you need to go and lose weight. That's sort of the general surgeon's approach to things, and they tend to refer for bariatric surgery or something like that. And they're concerned about these sort of complications with the wound and so on. Of course, the bariatric surgeon has a different perspective. So the bariatric surgeon receives this patient and says, okay, yes, bariatric surgery will be good, it will help you lose weight, it'll improve your health, it'll probably assist the repair, but how on earth am I going to get around this? How am I going to get my ports in? How am I going to do the operation? Is it safe to do this? And I don't want to do it open, because then how do I close things if I do it open? So there's the dilemma depending on where you stand and what side. So let's look at the position of the hernia surgeon. What's all the fuss about? What are they worried about? Well, there's good data over many studies, and this is a relatively small study, and I'll show you some other data, that shows an association of complications from attempted hernia repair as BMI increases. Yes, we know BMI is a crude marker, but that's what's used generally in the literature. So as BMI increases, there is a stepwise increased risk of surgical site infection and recurrence of that hernia. And also we know that obesity is related to metabolic syndrome, and metabolic syndrome, like sleep apnea, diabetes, hypertension, that cluster, is also associated in the context of ventral hernia with longer length of stay, complications, wound infections, readmissions and reinterventions. And so you have this combined effect, the metabolic effect and the size effect. There's some very large data sets, and this is from the American NSQIP database of over 55,000, so that again shows this relationship. As BMI increases beyond 24, it's stepwise. There's a linear relationship to risk. And because of this association of risk with increasing BMI, it leads to the notion that before I operate, I need your BMI to be less than 30, for instance, or perhaps less than 35, depending on which studies you look at and which ones you decide. But in other words, people set BMI targets preoperatively for their hernia repair. And the question is really, is that justified? Does that make sense? Where should the threshold be? There is a flaw in this way of thinking. Because what you're doing is you're taking a patient who is at risk because of their obesity at that point, and you're using that number to then justify where someone else should be. But here's the problem. It's the weight loss that confers benefit. It's not what the BMI number is at the end of that weight loss. In other words, this patient on the left who presents with a BMI of 50 is very different to the patient on the right who presents with a BMI of 55 but manages to lose weight and now is at a BMI of 50. These two patients are different. The one on the right has far less risk than the one on the left, even though the number is the same. And that's the problem with setting a BMI target. It doesn't really mean anything. What's more meaningful is, well, what sort of weight loss do we require to reduce our risk? That's really the question. So how much weight loss do we need? Well, there's sort of a number of parameters. One is, how much weight loss do we need to facilitate repair? In other words, if I look at this patient, I think this is going to be technically difficult. I'd like some weight loss, but how much weight loss do I need in order to make it easier, to make it feasible, to be able to get this hernia repaired? So that's one question. The other is what we're talking about, the fear of wound complications and so on. Well, what weight loss do I need to reduce that risk? And I think we can answer that one probably a little bit more sensibly. We talked about metabolic syndrome. We know that metabolic syndrome responds very well to as little as 10% body weight loss. And so already we can markedly reduce the risk of surgery in a patient if we can achieve, actually even as low as 5, but 10% body weight loss. How much weight loss do we need to reduce our risk of recurrence? Well, that's kind of the golden question. And in fact, the data doesn't really tell us that. Those studies haven't really been done. And then the other question, of course, is, well, it's all very well to lose weight, have your operation, but then what happens if you regain weight? Does that increase recurrence risk? And these are unanswered questions, but they're things that we have to grapple with. Here's the interesting thing, though. BMI alone does not predict how easy it is to facilitate your hernia repair. And so this particular study, I won't go through all the details of it, but it concluded that really it's more about where the fat distribution is, what's the body shape. And we all know this as bariatric surgeons. You know, you can have a patient BMI 35, but it's all central visceral adiposity with a big protruding abdomen. You know, that patient's going to be far more difficult to operate on than the patient who might be BMI 45, but is a pear shape, as we say, with the peripheral adiposity. We know this intuitively, but this is also true for hernia repair and the ability to close the hernia. So actually body shape might be more important, and one marker that's been examined is the waist to height ratio as a way of looking at that. And again, I'm not going to go through all the details of the study, but just to summarise, ideally a waist height ratio less than 0.6 facilitates safety in surgery and the ability to close these hernias. Now, for reference, about 1 kilogram of weight loss helps you lose around 1 centimetre of waist circumference. This is on average, it's all based on averages, but of course individuals are different. So I'm going to go through this kind of little sort of worked example, if you like. If you take, oh sorry, the laser's not really working, you'll have to read it down with me. So, if we take a male at 170 centimetres at 150 kilograms with a waist of 110, the BMI is 51, and at the moment that ratio is 0.64. If we achieve 10% weight loss, oh, I don't know what's happened there. If we achieve 10% weight loss, then we've got 15 kilograms, which should equate to about 13.5 centimetres. The final BMI is 46. Remember, that's much higher than the thresholds that the general surgeons were talking about earlier. They wanted the BMI under 35. But that final waist circumference is 96, which gives us a final ratio of 0.56, which is under our 0.6. In other words, that 10% is probably enough to help us get that hernia closed more adequately. And so I'm going to put it as a hypothesis, because we don't really have great data to tell us for sure, but probably 10% body weight loss should be enough to help us close our repair, reduce our risk of infection, deal with metabolic syndrome, and perhaps reduce recurrence. The problem is when you've got this guy on the table and that guy's lost 10 kilos, you kind of go, really? Is that going to make it easier? So the numbers can tell me, but emotionally I'm finding it hard to be sure. I don't know about you guys. But anyway, and I don't know whether the general surgeon's going to believe us either. This is not advancing now. Thank you. Okay, what happens when you mandate weight loss before hernia repair? So this is another important aspect. We're saying we want 10%. Now, these studies weren't done that way. This one was done with a BMI threshold of 33, so they made it pretty tough. And in the end, 75% didn't get their hernia repair, and that's over 27 months. Of those that did have surgery, 30% was emergent because they got complications from their hernia while they were waiting. So there is a risk of deferred hernia repair, and that has a clear impact on quality of life. And it's been demonstrated if you leave a hernia long enough, you'll get increase in size, and it's about 30% over 30 weeks of conservative management. 8% will end up in an emergency hernia repair. 28% in this study crossed over from conservative management into the repair group, according to intention to treat. And that group that crossed over had a higher rate of sepsis and fistula and mortality rate. In other words, if you wait for the weight loss to achieve weight loss to repair this hernia, you're introducing risk. And part of that risk is from the emergent repair. In fact, when you look at medical weight loss prehab programs for hernia repair, this is a randomised trial, and they had a very reasonable target. They actually set a target of 7% weight loss, with total body weight loss with medical weight loss. Well, 30% didn't complete the program. There was still a greater rate of emergency surgery. And ultimately, between the two groups, there was no difference in complications, no difference in recurrence at 2 years. And by 2 years, all the patients that had lost weight in the medical group had regained it. So all of that prehab didn't really help at the end of the day. You could have just operated on these patients and had the same result. And actually, systematic reviews of all the medical rehab programs for ventral hernia have really yielded that same result. There's a risk of deferred repair that counterbalances any potential benefit that you might get across the group. Maybe for the individual you might change something, but the problem is when you're trying to treat at scale. And that's the problem. Medical weight loss programs have high attrition rates, the weight loss takes too long. Maybe these studies were without the GLP-1 agonist, so that's an important caveat, and that might change things, it remains to be seen, but it is likely that that weight loss will still be variable. It's likely that it may be too slow. We may still have problems with deferred repair. And actually, our endoscopic solutions for weight loss have a similar problem. And it's in that framework that I'm suggesting that bariatric surgery does have a definite role. It is more effective, it's more rapid, it can achieve it more reliably, and it will be sustained in the longer term, potentially, which more effectively, which reduces that discussion about, well, does weight regain cause recurrence as well? But there are problems. You know, not every patient with a hernia that goes to get it repaired and is told you should have bariatric surgery actually wants bariatric surgery. That's a problem on its own. Then there's that technical feasibility I talked about. There's the problems of the hernia having a complication during that time of bariatric surgery. If we're going to do this, we're going to incorporate bariatric surgery, how do we do it? Should we do the bariatric surgery first and repair the hernia later? Should we do both at the same time, or should the hernia be done and then we deal with the weight loss to try to prevent recurrence? And overall, the data is poor. This is from a large database, 11,000 patients over 10 years. It is a retrospective analysis, and there's a very high selection bias here. But for what it's worth, if you do the hernia at the same time, there seems to be a significantly higher mesh infection rate. If you do the hernia before the bariatric surgery, you do see these higher recurrences, and that's probably the most consistent finding across all studies that have looked at this, that if you do the hernia first, you will have a higher recurrence rate. And if you do the bariatric surgery, lose weight, and then the hernia, your infection and recurrence is a bit less, but actually, interestingly, complications are higher, at least in this group. Now, there is a selection bias here because it's likely that the concomitant repairs were small hernias, relatively easy to deal with. So that may be misleading here. But if you compare the literature across all the three approaches using mesh, it's poor quality data, it's very heterogeneous, but what emerges is if you do the hernia first, you tend to get worse outcomes. What I will say, though, is robotics is probably changing that space, because robotics does give us access to in-abdominal wall repairs, and from the studies so far, robotics and minimally invasive techniques within the abdominal wall do not seem to have a risk associated with obesity and BMI, so that might be different. So if we're going to do bariatric surgery first, we should try to keep it simple. Remember, the primary indication here is weight loss for the hernia repair, not necessarily trying to solve everything about their obesity at that time. That might come later. So we try to keep it simple. Keep it in the supracolic compartment if at all feasible. A sleeve is probably your first choice of preference. If that's contraindicated, okay, that changes things. Because the problem is a bypass in the setting of a hernia that then obstructs is catastrophic, and that's what we're trying to avoid. Preoperative CT can help you with planning port placement, understanding the size of the defect, looking at the size of the sac, which can also be different and misleading. But the bottom line is, I think, be creative with your port placements. It's usually possible to get at least a sleeve done. You might have to come at some slightly different angles and use extra ports. Do what you need to do to be safe to get it there. And what should you do about the hernia? Well, the major recommendation is try to leave it alone as much as possible. If your CT shows just a mental plugging and you confirm that with your laparoscopy, leave it alone. The bowel's not in there. Hopefully it won't cause you any trouble. You can decide to repair a hernia at the same time, but I would confine that to small hernias or high-risk hernias where you feel like that needs to be done. And again, in that situation, aiming for a definitive, everlasting hernia repair isn't the aim. You're trying to get the patient through this bariatric operation, lose weight, and then have their definitive repair. And what you're trying to do is reduce the risk of bowel obstruction. So deal with the hernia in that framework. So trying to put all that together as a practical approach, an asymptomatic low-risk hernia, yeah, it's reasonable. Remember, many of these patients don't want to have bariatric surgery. We can try medical therapy, particularly with pharmacotherapy, but I would limit it probably to 3 months, because of the risk of the deferred repair area. Bariatric surgery certainly is feasible. You need to assess the suitability, aim for a sleeve. If you've got a symptomatic or a high-risk hernia, maybe intensive medical therapy for a period of time, if you can, to then encourage minimally invasive repair. A concurrent procedure is, I think the risk of infection is probably too high, but you can aim for a temporary repair, so not use permanent mesh. But ideally, if the hernia is demanding urgent attention, then the hernia is demanding urgent attention, and the weight loss becomes secondary to that. So in summary, preoperative weight loss is preferred, but it's not a deal breaker, particularly now with robotic techniques towards hernia. 10% body weight loss is probably sufficient. There is a risk of associated delayed repair if you leave it too long. The most secure strategy is probably a staged repair with bariatric surgery first where possible. But again, I think robotic hernia repair is a game changer here. Thank you for listening. I know I'm a little bit over, but I know we're missing so I've taken presidential sort of license with that. Please visit us at the Austin. If you're staying in Melbourne for a while, you're very welcome. Come and meet us at our unit. Thanks very much.
No, that's nice. The nice thing is that he will not complain about the running out of time. Huh? So next presentation is metabolic emergency surgery to facilitate orthopedic procedures. It's almost like we're going to the guidelines, the new guidelines, and difficult indications. So thank you.
Okay, thank you. And the big forward area. So thanks very much for letting me come to the meeting, and thanks for actually turning up. My name's Andrew Hardage, and I have no conflicts of interest. I'm an orthopaedic surgeon, director of orthopaedics at Austin, and the orthopaedic research centre there as well. So why is an orthopaedic surgeon talking at this conference? Well, hopefully by the end of it, we can work out why we should be working together, I think, with this group of people. So this is what I do, and with me, the hip replacement is, the grade chicaner for me is subcutaneous, and my kneecap subcutaneous. But this is what we have to go through to get through in some of these patients. Now, this is probably a normal patient for you, so it's not surprising, but for orthopaedic surgeons, it's really quite complex. And we have to go through this layer open, we can't do it with scopes, of over 10 centimetres, and that's before we've even hit the fascia on this patient, and then we have to go into the joint. So for me, that's one of the reasons I want to work with all of you, but there's other reasons, and if you look at it, pretty much obesity has an effect on pretty much every part of the orthopaedic surgery. Do they require it or not? When do we do it? Their access to surgery, as well as affecting the access of other people to surgery. Performing the surgery, the recovery afterwards, the complications and outcomes. So I'll go through each of those, and then we'll look at whether bariatric surgery may be able to help us with those. So the first one is requirement for surgery. So we know that the best way to facilitate surgery is not to have surgery at all. So can we avoid surgery in these patients? So we know that the rate of osteoarthritis is high with obesity, and you probably all know this, but it was interesting to go through it for myself. But it's not just the mechanical loading. There's all these, I'll probably get this right, adipokines or cystokines and adipokines, which are pro-inflammatory and can lead to the effect of the cartilage as well. So it's quite a complex thing. And also actually just their gait, how wide apart their legs are, how long they stand with two legs, and actually the slowing of the walking affects their development of osteoarthritis. And as you know, that this has an effect. It leads to about 5 to 8 times the relative risk of needing a hip replacement. And for every one BMI increase, there's an increase of 10% of their knee osteoarthritis. But thankfully, we know that bariatric surgery in the non-orthopedic operative group, it actually reduces, it can reverse some of the radiological changes, it reduces the frequency and intensity of pain, improves function and range of motion. And in many patients, as you probably know from the Michelle Dow's and Peter Chung, you can have the bariatric surgery and they just cancel their orthopedic surgery altogether. So that's in some people, but it's not everyone. So what about that group that do need surgery? Can we affect the timing? So the presentation with the evidence shows that it is earlier in obese patients. And when we look at knee replacements and hip replacements, we look at the area under the curve, and this is why I describe it to patients who are just about to need surgery, but they're young. So if you look at use on the left and then age on the x-axis and use on the y, let's say a knee replacement or a hip replacement gives them 10 blocks, so area under the curve gives them 10 blocks. If we do it at 40, that's going to wear out by the time they're 60. Then if we revise it at 60, it's not going to last another 10 blocks because it's a revision. So it might just last 5 or 6 blocks, and then they need another revision and so forth. So if we can push the graph forward and just wait a few more years till they're 55, those 10 blocks may last them the rest of their life. And not only that, but we weren't using robotic surgery at Austin 2 years ago, so just delaying it by 2 or 3 years may give them new technology. And now if you think about artificial intelligence, it may absolutely change what we do. May even be an injection to stop it or reverse it. But there's changes that happen very quickly now. And as we said, there's a lower list of revision and multiple revisions if we can delay things. What about the access to orthopedic surgery? As you know, it's very limited. We've got 1,500 people waiting for joint replacements at Austin alone. If you look across the state, you multiply that out. And for the obese patient themselves, they have increased requirements. So they might use high dependency, might need ICU, CPAP and so forth. So some places you can only do that at certain campuses within the health service. And access to those are much more limited. So a patient might, at our Austin campus, might wait 2 years for surgery. At the REPAC campus, it's 6 months. So a big difference. And when we do get to that patient, there's opportunity costs for other patients. So we know that the surgery takes longer, so we can do fewer joint replacements in the day, so somebody's missing out. And they stay longer, so the access to beds is reduced as well. And that's not just for orthopedics, but all craft groups. There's also, we don't do it so much in Australia, that there are some places maybe in the country, but in America they looked at the cutoffs that you were just talking about, and only 13% did not have a cutoff of BMI for refusing surgery. Most of them used 40 BMI, some used 45, very few used sort of 35, but 40 was the cutoff. But there's actually some of that group will improve, and I'll show you the graphs to show that even if you do have a high BMI, you can improve. So should we be refusing surgery that can improve you, even though you won't do as well as if you didn't have that same BMI? Performing surgery, I glossed over this, but in a knee replacement, if you look at somebody like this, for a medial parapatellar approach, this is a long way in, and you have to make a big ellipse, so a very long cut. It's very deep down. It's very hard to get the pins in and so forth. We can't flip the patella, so we have to make a pocket under the skin layer to flip the patella so that we can get into the knee. And even just simple things like here's the flexion space at the back, so we need to get to the back of the knee, so we need deep flexion, and we can only get to, say, 80 degrees in this patient. So actually you can't do the surgery because you can't get deep enough in there. And because of that, we can't see where we are. Technical errors are high in knee replacements. And in hip replacements, as we said, it's a long way in there. Also, some of the pins we've had to have, recently we had to cancel a robotic joint for a patient because we just didn't have the pins that were long enough to go in. And also the medial soft tissue position can leverage and make the hip unstable and cause dislocation. And for all surgeries, obviously these patients, there's an occupational health and safety issue. Sometimes you have to have special tables or even two of them. The limbs are heavy. They're really quite hard to control and the operative time goes up. With the recovery, there's evidence to show that obesity increases length of stay, the number of patients, the number of staff needed. They don't go home as much. They need rehab. And again, that affects it's an opportunity cost for other people. Complications, it's interesting going through the data on this. The early complications, so ligamentous, because you just can't see the ligament, dislocations, DVT and PE rates are higher, wound infections, deep infections, which lead to revisions, readmissions, and here's some graphs just to show you it's almost a linear or even exponential complication. So you ever look there for deep infection, it's off the chart once you get to 40, 45. Late complications, the revision rate because of those things is much higher. But interestingly, if you get past that, the revision rate's not higher. And I suspect that's something to do with the less active, so maybe they don't have that mechanical wearing out. But you can see there's no difference, which you may not expect, but for mechanical failure or aseptic loosening, you would think the load may affect things, but it doesn't seem to. And if they do need revisions, then they don't do as well. They need further revisions and reoperations, and they don't do very well in terms of functional outcome. The outcome, these, as I was saying before, they do have a good relative improvement with patient-reported outcome measures, and these are some of our results from Austin. So we collect PROMs in all of our patients now. So pain, you want it to go down. So you can see in that, I don't know what colour that is, it's teal or something, has gone down, so the really good improvement, but still not as good as the other groups. And here, Oxford Hip Score, that should go up if you're improving. You can see it goes up, but on the right, you can see that it's still lower than in absolute terms compared to the other groups. And the overall evidence in the literature supports that, but also they get reduced range of motion and some Harris Hip Scores and other things that are reduced. So in summary, obesity has an effect in all of these parts of orthopaedic surgery, but does bariatric surgery make a difference? There's a couple of things actually that it doesn't. So patients after bariatric surgery and then orthopaedic surgery have an increased requirement for blood transfusion. And in some papers, the hip dislocation rate is higher. And I wonder whether there wasn't a lot of discussion about reasons, but you would think about maybe the absorption and nutrition. And they often don't separate between the types of gastric surgery, whether it's a bypass or whether it's a sleeve and so forth. But there's lots of things that it does. And what it does do is improve post-operative complications, pulmonary emboli, respiratory complications, it reduces operative time, length of stay, reoperations, revisions, and reduce costs. And looking at similar to the ventral hernia thing is that should you do it before or after the orthopaedic surgery, the evidence shows that you should do bariatric surgery first. It's much better. Multiple papers says that. And when should you do it? If you can do it 6 months, you get some good results, but the best results come after 2 years, which is a long time, I suppose, for these patients. But if they've got reduced pain, then their urgency to do the surgery may not be as urgent. So that does decrease complications, tourniquet time and so forth. Is it cost effective? Yes. And would orthopaedic surgeons prefer bariatric before orthopaedic surgery? Well, there's no randomised control trials on this, but me asking around, the answer was yes. So thanks very much. And there's all the references there.
Hold on a second. Thank you very much. That was a very, very good presentation. I was just going to use my time here to ask you a couple of questions. So you think and I wish you come and talk to my orthopedic surgeons. You think most of the orthopedic surgeons got this message, or most of the orthopedic surgeons said you just go and lose weight and then come back when you lose weight and I can fix your knee because it's more dangerous? I
think being forced to go through the evidence, it would be good that if they knew all of this. I think it's the latter was that they don't want that first thing, which is the deep layer going through to do the surgery, and they feel that the patient won't do as well, I think. But if they knew all of that evidence, I think they'd be even more encouraged to.
Yeah. So what I see usually is they don't guide the patient to the right place, and they just tell them go and lose weight. They think it's just a lifestyle choice, diet and exercise, or diet or whatever you can do, and then come back and see me. Well, they need to go and see an obesity specialist, and especially if we're talking about this high BMI, bariatric surgery will be the answer.
Yeah, on that, we do have a sort of a streamlined thing at Austin.
Seems
where they
like
can
you
go into
work on that.
system. Yeah. And who presents at Austin each year? Wendy, each couple of years. And she talks about, telling a patient to go away and lose weight. She says that there's only 3% that can do it, and they're fastidious and they calorie count and they're obsessive with their exercise. And all these patients, the first thing they say is, I can't exercise because my weight. And
then the following question is, what if we do a sleeve and these patients lose weight and they go from a BMI of 45 to a BMI of 30, and now they feel much better, less symptomatic, and I know that the knee is still damaged and you still wanted to do surgery, but is there a data that shows that may decrease the need for operation when they lose that much weight, or just delay the operation like you were stating, delay it to a later age?
Yeah, there's not a lot of long-term papers about if they cancel, will they come up for surgery, but there's definitely evidence of bariatric surgery, people cancel their surgery, and Michelle Dowsey.
Cancel it and then...
Yeah, but I don't think we know of a 5 or 10 year thing about it.
Because later on they may still need it, but they may postpone it later on. Thank you very much.
For those reasons, if you can move it later technology might last the rest of their life, so it's good even just that.
Thank you very much. Excellent. That was great. Thank you. So the next part is interesting, debates. We all like debates and we all like to see. So metabolic emergency surgery to facilitate surgery on patients non-ambulatory. And we all have patients that come on a wheelchair, and then so what's the best option? So we're going to have endoscopy, we're going to have pharmacotherapy, and then we're going to have the against all the above. So Christine Steer is going to talk to us about the role of endoscopy on these patients. Those are patients that sometimes we don't want to do surgery because we know that they're not going to do as well, or they're more risky.
Okay, can I have my presentation, please? Maybe not.
There you go.
Okay, here we go. Okay, thank you, first of all, for having me, Jaime. But
Thank you.
I don't know whether I'm the right one for endoscopy in this case of obesity class 5 with a BMI above 60. And I just can tell you, these are my disclosures, which have nothing to do with this presentation. I can tell you that we've done a study on this already some years ago, which was called Fast Track Rescue Weight Reduction Therapy to Achieve Rapid Technical Operability for Emergency Bariatric Surgery. And as you can see, we already defined, or we tried to define, the emergency bariatric patient. And I think this is the one we are talking about today. And this was a proof of concept study. And what we developed was really a score, how you can score such patients, whether they need really a very, very quick surgery to get rescued, to really save their life. And you can see that there are some facts included in this score, like pulmonary status, which was indeed the point why we developed this, because there were a lot of patients coming with complete pulmonary insufficiency, needed intubation or tracheotomy, and the rest of the points are including morbidity itself, but pulmonary status is really a very, very important point in such patients. And we did a propensity score matching with 2 groups, and you can see here on the left side, these were patients that got classical endoscopic treatment as a bridge to surgery with an intragastric balloon. And you can see they really had a high BMI with a median BMI of 77.5. And we matched that to patients that really needed emergency rescue weight loss operation who got at that time a medical treatment, and you have to know that at that time there was not so much hype about medications because there was none approved yet. There was liraglutide available as Victoza, which was a medication for diabetes, but we knew that this leads to weight loss, and we combined it with amino acid infusions, so that these patients don't lose too much muscle mass during the treatment. And you can see that the baseline weight of those group also was above 70, with 73.3 kJs per square meter. So what you can see is the outcome, and this is the most important message I want to tell you. If you treat patients with endoscopy to bridge them to surgery, it takes time. At least 6 months for the balloon treatment. And if you don't have this time, you have to treat them in another way. You have to treat them quicker. You have to bring them really quick to surgery to save their lives. And you can see with the medical treatment, we had a treatment duration of mean 20 days, which is a very quick achievement of technical operability. Although both groups nearly lost the same weight. The group with the balloons lost 21 kilos within 6 months, while the group that was treated with the combination therapy lost 26.1 kg. So we brought all of them to operation. We did in all of those patients sleeves, because these were really patients where you can't do a very extensive laparoscopic operation with a BMI that is above 70. And what you can see, and I'm sorry, the top line is not right because the medical group is the one on the right side. What you can see is that you can predict much better weight loss if you give medication under hospital conditions. Then you can predict weight loss if you do an intragastric balloon, although in the mean they lost the same, but you can predict it much better if you do the medication. So we validated this emergency score, and this is indeed the take home. After these 5 minutes I have to talk, that I want to tell you there are clear criteria for that. For non-ambulatory patients, for the non-emergency patient, of course, endoscopy is a good option. The balloon is proved as bridge to surgery. Nowadays, you can also alternatively do an endoscopic gastroplasty. But if you have to achieve a very quick operability, in our mind, you really have to treat the patients with medication. Although this is difficult in Germany with the insurances, but anyways. And this defines the bariatric emergency patient, and this is really a focus we have to, or this is really a point we have to focus on, because this is something we haven't defined before. Thank you.
Thank you. Well, now let's focus on pharmacotherapy. Alex.
Hello, I'm Alex Miros. I'm an endocrinologist from the United Kingdom. I don't have any slides. This is a debate, and generally in debates, the data are rather light. So what do we know so far from probably the best study in the field of 400,000 patients in the in the US and Canada, is that as body mass index, forget about comorbidities, as body mass index goes up, the risk of mortality goes up. So that BMI over 50, 55, the risk of mortality is 5 times that of body mass index of 30. What we also know is that any weight reduction before surgery reduces mortality. And this is a dose-dependent effect. 0 to 5, 5 to 10, 10 to 15, you get a reduction in mortality, as uncommon as mortality is after bariatric surgery. And what the meta-analysis of a number of studies has also shown us is that weight loss before surgery also reduces complications. This is still a matter of debate, but it looks like the numbers are pointing to a 20 to 25% reduction in complications. So it's not bad. Now, the title of the debate is, what are you going to do with a person who's bedbound or wheelchair-bound, etc.? But what we need to understand is, why is the person non-ambulant? Because not every non-ambulant patient is the same. Are they in bed or the wheelchair because just their body mass index is high, but they're cardiometabolically very well? Is it because they have got just osteoarthritis as their obesity-related complication? Or is it that they are non-ambulant because they've got horrific heart failure, and that's the reason why they cannot walk? And obviously understanding that is really, really important. Why? Because what you need to do then is you need to stage the patient with whatever staging criteria you use in your service. And you may decide that this patient is so advanced in their disease that there is no point in doing anything at all. Therefore, this patient can be just palliated, which is absolutely fine. And it's an absolutely fine decision to make. And I think we need to be more making these decisions a little bit more. They're difficult ones, but we need to be making them a bit more. We need to be a bit more brave. Now, if you think that the patient has got a chance, maybe they are not as advanced in their disease, maybe they are not for palliation, but if you think they have got a chance of being operated, of course offer them a way to achieve the weight loss that's needed, whatever you decide that to be, to make them operable. So what pharmacotherapy will do with the agents that we have got available at the moment, if you are lucky, you're going to get an average weight loss of 22%. That's the average. 40% of patients with tirzepatide, for example, will lose more than 25% of their body weight. And losing more than 25% of the body weight can be enough to bring this patient closer to surgery, convince your anesthetist to get them anesthetized, maybe even start making the patient ambulant before the operation. So, of course, you have to hope that the patient responds to the medications, because there is a chance that they might not, or that they do not tolerate the medication, and there is a chance that they might not. So we have got pharmacotherapy, which will be used as a bridge to surgery. But the other thing that you can do, of course, is if you don't think that the response to pharmacotherapy is that good, you can consider combining pharmacotherapy with endoscopy. The data on that are evolving, but if you consider that the two treatments may have different mechanisms of action, if you combine them, you may get an additive effect, enough to convince your colleagues to operate on this patient. So to summarize, stage the patient, decide whether you need to invest time and resources on them, and if you do, yes, treat them with pharmacotherapy, plus or minus endoscopic treatments. Thanks for listening.
So, good arguments about not going to surgery first. Now, Camilo, do you think they're right or not?
I was planning to do a presentation, but I end up deciding not to.
We'll get to it.
Basically, because it's very difficult to see how these patients could go through. At some point, some patients are definitely not even able to, as a concept of the session is not able to be ambulant. So I think you have to try whatever option you can, where you can do it or not. And honestly, when I tried to call Cheetah, basically we are doing that on those patients, and we are achieving actually really very good results. However, many of these patients are at some point, they have crossed that line. And then when they have crossed that line, and I think the three things we've seen in terms of crossing these lines are basically when psychiatrically they are not able to follow any indication, because we know that this is a disease, we know that there's some problems, but at the end of the day, when some patient is non-ambulant, and basically we are speaking about patients over 250, over 200, 250 kilos, and these are definitely very difficult patients. So there are many lines that we need to not be crossing in order to even propose any of these options. A non-compliant patient that is not willing to do any change in their lifestyle or any effort in the things they are doing, maybe they're not even suitable to a medication or even an endoscopy. However, on the other side, I have many good experiences on patients. The last one was a patient of 270 kilos that came to my office after having an open gastric bypass 20 years before. So I'm coming for a revisional surgery. So as I said, there's no way I'm gonna do an revisional surgery on an open gastric bypass, transmesocolic with posterior abdominoplasty. These are the things that you have to really totally run away. So when we are discussing if these patients are out of this line, I would say that they are definitely out of the line of surgery in many ways. But I have to say that in this patient, I had to eat my words in every manner, because when I started putting these lines, as I tell, and many times these patients say no, but when they start at least saying yes to some of the commitments we need to do for these patients to start the treatment, some of them start having results. And in this particular patient, I started with liraglutide. The patient lost 30 kilos with liraglutide. It was 250 to 220. So, but at least with 30 kilos less, I underwent gastric pouch reduction with endostitch. And doing that, the patient went down until 160 kilos. So he lost basically 60 more kilos with the ESG only. It was basically pouch reduction plus gastrojejunostomy reduction. And then I underwent a biliarization of the bypass done laparoscopically, because I did that after the patient had lost 70 kilos. So it was really a piece of cake. It was quite easy. The patient was very fluffy, no problems. Everybody was loose inside. Even having an open gastric bypass, I was able to transform all the surgery in a biliary bypass with a common channel, with a total alimentary length of 4 meters, and the patient ended up with 125 kilos. That's his actual weight. So that's why when they offered me to reboot, I can reboot so many things in terms of, if the patient is too unstable psychologically, if the patient is too unstable medically, we could say no so many times. But I think these patients deserve, if we start putting these lines, and we can discuss here with Jaime which are those lines, because there must be boundaries where we can say, I won't go there. And my boundary, at least surgically, is I won't do a revisional surgery in an open gastric bypass transmesocolic with a posterior abdominoplasty, because that's definitely a suicide mission, and we need to. But then, I ate my words when I staged this treatment, doing medication, doing endoscopy, and finally doing my surgery. I did the surgery at the end. And the patient now is really, nobody wanted to touch these patients. And these are the patients that go one unit to another, receiving that, no, they already had their opportunity, there's no options, and basically everybody says no. That would be my my opinion based on this, and that's why I didn't have slides, because I was totally in disagreement.
So before we go to that question that you had, I was going to ask you, so is there any case scenario in which you would bypass pharmacotherapy, endoscopy, and just go straight to for example, for a sleeve gastrectomy, which would be the most simplistic one? Which is the patient that you will bypass all of those options and you will go against all those options and then go straight to surgery? Is there a scenario like that?
I think that today, although some people are more happy of treating obesity surgery or obesity disease like a chronic disease like hypertension or diabetes, I think it's better to treat it like as a cancer, because you need to see which is your best approach. Are you going to go to an esophagectomy in a lower esophageal cancer that have positive lymph nodes? Are you going to say, oh, no, I'm going to go straight to surgery, I won't do radiotherapy because I don't like it? No, the treatment indication is to reduce tumor cells, reduce the possibility of lymph node dissemination, and then do your surgery when you have your best chance. And I think this is the same thing. Sorry.
Are you okay?
So no.
Let me hear that question, and I'm gonna ask you follow-up questions here. Go ahead.
Thank you, Jaime. Thanks for this from Monash. My question's for Alex. Alex, we're dealing with patients who are really out of the ordinary in terms of their risk profile. And one thing I've often wanted to ask an endocrinologist with experience in the field, is there a role for things like anabolic steroids and protein? Is there a role for things like hypersupplementation of thyroxine to try and change the patient's physiology, to try to change their metabolic rate as a baseline before considering going ahead with surgery?
I wouldn't do that, both because there is no evidence and because some of the treatments that you have mentioned may actually be quite potentially harmful, like thyroxine. There has been some thought of using anabolic steroids in order to preserve muscle mass after weight loss, or growth hormone even, but I wouldn't use it in those patients that we are discussing here. I would say that, especially now with the pharmacotherapy that we have, which is quite safe, I think I would go ahead and use it instead. The only thing I would like to differentiate here is that I think Camilo is suggesting that those people who are really big in terms of BMI also have more psychological, they're difficult, tricky patients, and I'm not sure that I necessarily think that that is truly the case. So I don't think they are bad people, non-compliant, except and have more psychological complications or psychological comorbidities. I think they are at a different spectrum of the disease, and whether they have psychological comorbidities or not is not necessarily related to the body mass index. They might be completely psychologically fine, even with a weight of 250 kilograms, but they might be either too big and therefore they cannot walk, or they have got, which to me would be worse, for example, heart failure, which makes them not able to walk. So I think that we should treat them in the same way as we would treat someone who has got a body mass index of 35, not think that they are necessarily more complex psychologically.
Don't try to make me look like a stigma guy, okay? So don't start that game, because I'm not, okay? But you have to be, and we have to agree that these patients have more psychological complications because they have underwent worse thing. If you bring me to my office a cancer patient stage 4, he's definitely going to have more psychological complications than a patient that has nothing in the breast.
How do you know?
Huh? Because
How do you know?
Because that's information. They have more complications. They don't have more. They are not more eager to have complications, but they have been exposed to more problems, so they have more things. So if you have this patient wanting to kill himself every minute, probably it's not the best time at that moment to offer a super complex compliant treatment. So don't do that.
I was just trying to say
I'm trying to fight with him. No, no.
Yeah. 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 Okay. Well, maybe. But the other thing also to consider, and I just need to throw that in anyway now because that's important, is in those patients, please don't forget to check for genetic obesity. I'm talking about now, they're really 250s, etc. Don't forget to do that. There is a possibility that you might hit something. We are now in a position to check for genetic obesity, and we can now even treat some of the genetic obesity and make these non-compliant patients with the abnormal dynamic lose about 25 to 30% of their body weight.
Go ahead, your question.
Camilo, I'm a fellow endocrinologist like Alex, and I've had a fair bit of experience with a lot of larger patients, more than 300, even some more than 400. The one good thing is, to get to that weight, they usually don't have metabolic complications, such as diabetes and hypertension, because if they did, they wouldn't make it there. So most of their complications are functional: sleep apnea, reflux, and arthritis, and immobility. So in that sense, it's good. And to answer your question, the bottom line is, the bigger you are, the higher your metabolism is. And that's been shown with indirect calorimetry, with double-labelled water studies. So thyroxine, you don't need to. So the bottom line is, these patients are just very good at consuming very large amounts of energy. So the issue is, how do you stop them? And I think probably the most important thing that I've found is, for these patients to survive, you need to make them mobile. And I get so many phone calls from people in other hospitals about how do we prepare these patients. When they're in hospital, you don't starve them. You've got to get them mobile. So the three things they need the most are physio, physio, physio. If they can walk into your room, onto the operating table, they've got a chance. And I think, and in my experience, I have to agree with Camilo that it's rare that I see someone at that size that hasn't got a significant psychological issue or trauma. Yeah, not because and Camilo, usually in that situation, a lot of the time, it's something like a psychological trauma. They were big, then one of their parents died or something else happened, and that's when they go in their room and they just shut up. Or something like, if you've seen the movie The Whale, with situations like that.
Camilo thanks you.
Yeah, Camilo.
I would just want to make the point that if we are going to score something, are we voting or something?
Yeah, we're going to vote at the end, but hold on a second.
No, but let me answer this a little bit, because what I was talking about before is such patients that really are so big that they have a problem to expand their thorax. And I think pulmonary insufficiency in such patients is really a significant problem. They are a little bit like a whale on the dry because they can't move. It's too difficult to expand their thorax with their muscle force.
And Christine, when they can't move, the important thing is to work out who's bringing them their food.
That's true. That's true. That speaks for Camilo. There are often problems with feeders. Oh, wow. Absolutely, yes. Wow. That's absolutely true.
Codependency is
social dynamics of that relationship.
Ahmed?
And that's what I was referring to. So I defended Camilo just before I tried to make it, a little bit softer. But Alex, don't worry, I'm going to come rescue you now.
Alex. Poor Alex
So Alex, I think even if there is more psychological trauma, it's not a reason not to treat. It's just something that we have to take into consideration in forming our treatment plan. Yeah, and I think that's really.
But what I was saying is that also I totally agree with you that they don't have the right to have more or less problems than other patients. But if someone is non-ambulant, there's someone, as you said, giving the food.
Yeah.
So that person has a critical relation in the outcome of the first part, that we are trying to get these patients move or get them into the OR.
Correct.
And the other thing I would say that I think today it would be the treatment of choice to start pretending to do something before prepare the patient in drug or whatever to make them at least more functional.
Yeah, that's right. I think we're all on the same page, and I would certainly echo Nick's comments about trying to get them mobile. This session is really about the non-ambulant patient, not just the big patient. So the non-ambulant patient, so I just want to ask a different question maybe to Alex and Christina, maybe you can or can't answer it, but there's something specific about that non-ambulant patient other than the psychology, which is they're not expending energy. Yes, I know their metabolic rate might be a little bit higher, but their energy expenditure is so low that even... Yeah, and we heard this morning that the GLP-1 agonists don't necessarily change that, but surgery does. So my argument is, well, if we're going to do anything... Well, firstly, I have a question, which is, well, how effective really are the GLP-1 agonists or a balloon in someone who is non-ambulant? That's the critical thing.
But this is exactly what you said. What we did is physio.
Okay, so
They
that's
sa-
why
they
I want
had
to
a,
emphasise
I
that
don't know the
point.
expression in English. They had a bed cycle. Is that right?
Or just moving.
Yeah.
They've got to be able to stand and then you walk them.
Yeah.
They
So-
have to be able to walk into the surgeon's room.
But then does the fact that surgery also assists that metabolic aspect, make it the first line of therapy here? That's what I'm going to throw in.
One thing I was based on what you said is that these patients, I had the experience with I participated in two TV shows on super big patients, and maybe they can have a higher metabolic rate or maybe lower in some cases, but they eat a lot. It's amazing. They can eat, I don't know. I once I did the exercise of a patient of 270, 250 kilos of how they could eat 2 boxes of eggs every day, 24 eggs a day to start with. And then so it's totally different scale of numbers. So it's definitely the person, and basically if it's not ambulant, the person that is giving the food is critical, and the codependence on them is going to be critical. And even if they are not so or have more or less psychological problems, it's critical. And I think at least that's why I think endoscopy plays a role, such an important role, also because from the inside all the patients are the same, and for us really it doesn't. We don't care. And in my experience on those patients, DSG has been fantastic to start with.
So we'll take one more question, one more comment. Alex wants to defend himself.
Yes.
So, okay, well, let Alex defend himself. One more question, and then we'll go to a quick vote, because I wanted to make sure that Camilo feels that he didn't win, and then we'll go from there. So, Alex.
2 points. The first thing is that the person who's got the body mass index of 70 or 80 eats a lot. Oh, yes, by definition, so that shouldn't come as a surprise. The reason why they eat a lot is because their appetite regulation system is much more disturbed than someone who has got a body mass index of 35. So the feeder, as long as there is no dysfunctional relationship, the feeder is responding to the person's hunger. They're not necessarily doing anything harm. And denying food from someone who's hungry is very difficult. With regards to energy expenditure, there's a number of different, there is dietary induced, basal metabolic rate, and activity related. The reason why bariatric surgery may be more effective is because the activity related energy expenditure can be proportional to the amount of weight loss, okay? So, and therefore medications would be less effective in that. The only difference here is when it comes to basal metabolic rate, is the introduction of the newer agents that include GLP-1 and glucagon. Because glucagon at low doses can increase basal metabolic rate. So you might get a weight loss independent effect there.
Without any side effect?
That's different.
Okay.
Last question, and then I'm going to take a quick vote.
Actually, I want to make 2 comments. One is, we actually measured over 2,000 people who are very large with indirect calorimetry and published in 2004. And basal metabolic rate makes up 80% of your energy expenditure. And when we went back and did regression, the bottom line is, as you get older, your basal metabolic rate goes down by a factor of 2. As you get heavier, it goes up by a factor of 10. The taller you are, it goes up by a factor of 4. And men have a higher metabolic rate than women by about 250 calories. So the bottom line is you can plug all those numbers in, and as Camilo said, when you're so large, the numbers just fly. And these patients, even doing nothing, have far more energy intake than Ahmed doing all his exercise. Second point I want to make is, sorry Alex, with a lot of the patients that I see, there are three reasons why people eat. One is, they enjoy their food. Two is they want to escape from some feeling. And three is they've got an entrenched behaviour. Most of the people that get to the sizes that we talk about actually are trying to escape some feeling. And if you ask them, most of the time, they actually don't get pleasure out of food. And it's not appetite, that's not hunger.
How do you know?
I ask them and they tell you.
Oh, okay.
Yeah.
Right, and you believe that?
I definitely, and I also believe they're partners and other people. But
Sure. Okay, all right.
So who of you have seen the movie The Whale? And if you haven't seen it, just go and watch it. Just go in Amazon or whatever movie stuff that you can get access and watch it. That's the typical patient that we're talking about. It's an impactful movie, especially for most of us that are in this field. It will impact you. So how many of you think that Camilo made a good argument and won this debate? This is Camilo. How many of you think Christine and Alex did a better job than Camilo? Wow. Okay. Well, let's move on to the next talk. Camilo, you have anything last words to say? You're fine. Are you okay?
No, I would argue on Christine on which are your protocol on these patients. What is your the stage?
This is, like I said before, indeed, if there is a chance to do endoscopy, I'll do always endoscopy because it's covered by the insurance then. But if they are really emergency patients, and I'm afraid that they will die without any surgery, I'll do the medication and that's it, and bring them very quickly to surgery.
But you always in your protocols try to start with medication, and do you wait until, because what I've done in a couple of patients is that when they stop losing weight, and the patients are very variable. There are some patients that they can, the one that was my super success for those patients, they keep on losing weight, and at some point when they started Anadir, then I said, okay, now we go for the ESG, and when the ESG stopped, then now we go for the surgery.
Yeah, but these lines are really difficult because we were trying to decide when can you do an operation on such a patient, and what we did is that two surgeons try the impactability of the upper abdomen to say, yeah, now you can do a pneumoperitoneum. So these are lines that are really difficult and not objective at the end. But it is, you have to define it within your own center because it's really difficult with objective criteria.
I think, Camilo, before we leave, you have a quick commercial, and then we'll go to about your Congress next year.
Well, I want to give you this invitation for the IFSO 2025 in Santiago, Chile. It's going to be from 9 to 12 of September 2025. It's going to be in the beautiful city of Santiago, not as beautiful as Melbourne, but almost. You will have, because it's quite as tricky as Melbourne, I would say, in terms of weather. We will have probably wind, sun, maybe rain, but for sure we will be able to go to the beach, or you will be able to go to the ski. So the good thing is that the ski resorts are less than an hour from the city, and the beach is also less than an hour. So you can choose whatever your activities, and the program, I think this has been a really fantastic program with lots of discussion. And I think we have embraced the concept of this program with more plenary sessions, with a lot of debates, and promoting that more and more delegates can come to Santiago. So I leave the invitation for all of you, and we hope to send your abstracts. I think the level of the abstracts this year has been fantastic. You will see in the presidential session, there's going to be presented the best abstracts, but there are sessions for the top papers. I think those are the main concern about these meetings. And I want to give a big hug and congratulations to Ahmad Ali, because he's done a great job here, and we wait for all of you in Santiago. Thank you, Jaime.
Thank you. We're going to move on to the last presentation. This is in regards to autoimmune arthritis patients. Thank you, Camilo. So these patients can also be tricky, so let's see what we have. Somebody left the phone?
Thank you. My name's Michael He. I'm a surgeon also here in Melbourne, and I'd like to thank Ahmed and the organising committee for the opportunity to present. I have no disclosures relevant to this presentation. So, autoimmune arthritis and bariatric surgery, this is one of those sort of common surgical situations that we see as bariatric surgeons. And it's actually quite common. Autoimmune arthritis covers a range of different disorders, and people living with obesity actually have a slightly higher incidence of autoimmune arthritis than the general population. Weight loss in this group is really important for the normal reasons, the metabolic benefit, but also in the autoimmune arthritis group, there's probably a benefit from weight loss in terms of disease activity and certainly from mobility if they have arthropathy. But as GI surgeons, we're all kind of aware that these patients also have an alteration in their perioperative risk, and this is in terms of postoperative infection, staple line healing, but also long-term concerns with respect to symptoms and bariatric surgery complications. Now, unfortunately, there are no established guidelines to help us really kind of guide decision-making in this space, and the evidence that's available is a little bit sparse. So it can be challenging to make the right decision in this patient group. This is data from a paper that was published and presented at the American College of Rheumatology conference a couple of years ago, and they asked board-certified bariatric surgeons how they managed disease-modifying anti-rheumatic drugs in the perioperative period. Blue is withhold and orange is continue, and you can see over this range of drugs there's basically no consensus between surgeons about how they manage those agents. So this is a pretty big topic, and this is only a 10-minute presentation, so I thought I'd focus this presentation on a particular case from our unit. This is patient MM, she's 35, height's 160 centimetres, weight's 160 kilograms, so her BMI is over 60, lifelong obesity with a family history of obesity and comorbid conditions, and relevant to this presentation, she has psoriatic arthritis. Throughout her life, she's required intermittent high-dose steroids for flare-ups in her arthritis, and she currently takes mycophenolate and has her arthritis in remission. When her arthritis is really bad, she can only ambulate with a 4-wheel frame, but now she can walk 100 metres, which is good for her. She's an active smoker, which for us is a limitation to access surgery, but also is a concern for long-term ulcer risk. And of course, she's failed non-operative weight loss. So I guess in first principles, we'd all be very happy to offer this person surgery, and I think we'd all agree that meaningful weight loss would offer a lot of longevity benefit, metabolic health benefit, but probably also disease benefit if it could be done safely. This is a study from a single centre. It's a retrospective analysis. They looked at 53 patients that had bariatric surgery whilst being treated for autoimmune conditions, and the main conditions were rheumatoid arthritis, psoriasis and lupus. These patients had their immunosuppression stopped for 2 weeks before and after surgery. And what you can see is from this table on the top right, the surgical outcomes are very good. The early and late complications rates were in keeping with what we'd expect from modern surgery. The bar chart on the bottom left shows that their weight loss was also consistent with what we'd expect from modern surgery. And importantly, they looked at the use of disease-modifying anti-rheumatic drugs out to 3 years after surgery. And what they were able to show in these patients is that there was a significant reduction compared with their preoperative baseline. So they concluded that bariatric surgery could be offered to these patients. It was safe and effective and actually had some disease-specific benefit. This has been replicated. This is another single-centre study, 89 patients in this series. Again, a whole range of different immunosuppressant drugs which they stopped before and after surgery. And they were also able to confirm very good perioperative outcomes, good long-term complication rates, and excellent weight loss. Weight loss in this study out to 5 years was almost 30%. So in high-volume specialist centres, this surgery has been offered and performed very safely with good outcomes. But if we look at the data from more of a community surgery perspective, there's a bit of a different story. These are two studies that have looked at the NSQIP database, and they've taken out 2,000 patients that have had surgery on steroids or other immunosuppressants. And the story is that the 30-day mortality rate is actually 3 to 6 times higher in this group when you look at a community level, and the morbidity rate was twice that at 30 days. The second paper did a meta-analysis looking at the measurable risk factors in the NSQIP database, and steroid use was the most strong predictor of mortality and morbidity in the whole data set. Now, procedure selection is also a little bit nuanced in this patient group. So this slide focuses on ulcer risk, but obviously something like reflux or Barrett's also has implications when you're talking about these patients and trying to choose the right operation. This is 3 meta-analyses that have looked at the risk factors for marginal ulcers after gastric bypass surgery, and there's a little bit of discrepancy, but basically they showed that steroid use and non-steroidal anti-inflammatory drug use is a pretty significant risk factor for ulcers after gastric bypass. We know that at a baseline, gastric bypass patients can have an ulcer risk of up to 10% in the long term. And obviously in the autoimmune arthritis group, the use of these medications is much higher, and we think this has really important implications in procedure selection for these patients. And then finally, I just wanted to mention that all the anti-rheumatic drugs are actually quite different. So there's a really long list of these days, and I think it's beyond the scope of most bariatric surgeons to even know the names of all these medications. Our patient was on mycophenolate, and I think you have to really interrogate the specific mechanism of action of each drug and the implications of stopping the drug or continuing the drug, and obviously do that in conjunction with the rheumatologist. Mycophenolate's been studied. In the first study on the right-hand side, this is an animal study where rats had a colonic anastomosis and then were randomised to treatment doses of mycophenolate or control, and the treatment group actually had a much lower anastomotic burst pressure, indicating an adverse effect for the mycophenolate. The second study looked at taking random biopsies on human patients who were taking mycophenolate, and what they were able to show in random biopsies was that the majority of patients had evidence of ulcerative esophagitis, reactive gastropathy, and duodenal ulceration. So this is back to our case. Our case was discussed in a metabolic MDT. It was decided that in spite of a very high BMI, a sleeve gastrectomy would be a better choice due to her smoking risk, her risk of ongoing steroid use, and her requirement for non-steroidal anti-inflammatories for symptom control. She underwent intensive prehabilitation, was able to stop smoking perioperatively, and she had an uncomplicated sleeve gastrectomy. This is a 1-year weight loss, which is actually a little bit more than I thought she would achieve. Unfortunately, she's back smoking, but she's back on her mycophenolate, and her disease is improved, and she has much greater mobility. So, in conclusion, metabolic surgery in the group of patients with obesity and autoimmune arthritis is highly likely to be beneficial from a metabolic standpoint, but also from a disease-specific standpoint. In reality, they probably are much higher risk, and we'd like to consider referral to a tertiary or quaternary referral centre. In Melbourne, we like to refer them to Professor Ali at the Austin. In practice, it's important for the surgeons to really be aware of each agent and the pros and cons of stopping them in the context of surgery. And of course, procedure selection must be nuanced in this group. Thank you very much.
So any questions? So bottom line is selection of the procedure will be critical in the number of medications that they're taking. Yes, go ahead.
So the question is...
If you want to go to the microphone so I can hear.
First question is, which one is your preferred out of the medications. And the second, in terms of complications, based on their mechanism of action. And the second one is, if you are going to decide to stop treatment, whatever the treatment is, how long do you usually do that for? I know it will vary from patient to patient, but roughly what do you do in your center?
Well, first question's easy. I don't have a preferred medication. They're all least preferred. I think that stopping the medication is also nuanced, and what we've done is we've basically just looked up the half-life. And I think we know that biologically it's probably cleared 3 to 5 half-lives, and so we use that as a guide, and then we balance that. We talk to the rheumatologist about the risk of a disease flare-up by stopping the medication. But I guess ultimately, a bad bariatric leak is going to be much worse for your health-related quality of life than a rheumatic disease flare-up, I think.
How long after do you restart?
Well, I'm very conservative, and I also wait at the same time, so it's made up, but it's 3 to 5 half-lives to stop and 3 to 5 half-lives to start.
You have a question?
Michael, thanks. That was great, especially. I know we asked you up at short notice there, so you did a great job. In one of the earlier sessions, yesterday actually, in one of the pre-Congress courses, we were discussing ulcer disease and so on. And some information that came out to me that was I hadn't known was that in fact non-steroidals, even in bypass, is reasonable if you can limit it to 30 days and PPI cover. Did you meet any discussion of bridging? Have you used it yourself to help control the arthritic pain whilst they're off their immunosuppressants?
Anti-inflammatories?
Yeah, and NSAIDs.
Yes, we have, and I mean, as we all know, we often have patients that go home and sometimes take medication that they subsequently become aware is an anti-inflammatory, so they don't necessarily follow our instructions. At St Vincent's, we have a pretty liberal policy with the PPIs, so our bypass patients are on PPIs for 6 months, and if they have one anastomosis gastric bypass, it's 12 months. So we think the use is probably okay early on, but they are protected in our group by quite a high dose of anti-acid therapy.
Yeah, just and that was interesting data that I saw yesterday. It was at 30 days, it's pretty reasonable. Long-term use is where the risk seems to be mostly. And then the other, very quickly, many years ago actually, I looked at this for giving a talk to a group of rheumatologists, and I found there was some discussion about the potential, particularly for the bypass procedures, to have weight-independent effects on the arthritis, particularly in the rheumatoid group that had been looked at. I don't know if there was any follow-up on that, and when you looked at the literature a little bit more recently.
Well, I couldn't find any sort of specific biological studies, but everyone sort of alludes to the fact that the obesity is a pro-inflammatory state, and again they talk about the adipokines and the secretory hormones from the fat, and it's difficult to see exactly where all this, going back in the literature where it comes from, but certainly even in the rheumatology literature they seem to speak about the disease-specific effects of weight loss.
Excellent. I'm glad we finished on time. Thank you very much. And don't forget to come to the opening session ceremony at 6 o'clock in the exhibits room. It's going to be nice. So we'll see you there. 5:30? 5:30, okay. We can start now.